Hi, I'm Dr. Kevin Zorn, Director and Founder of BPH Canada. And today I would like to spend a little time going over some of the highlighted BPH abstracts and presentations from this year's AUA meeting in San Antonio, Texas. Among all of the BPH abstracts and presentations, there were certain key presentations which stood out. The ones we're going to highlight today, first being P213, one of the plenary sessions where the presentation was delivered by Dr. Klaus Rohrburn, looking at the preliminary randomized control study, looking and analyzing missed minimally invasive surgery, specifically the Urolift, versus medication in the other group, which was Flomax, in initial treatment of BPH associated with LUTS. So in short, this was a study where it was a one-to-one enrolled study called the Impact. This is the initial 3 months data. So they're really looking, the long-term plan of this publication will be a 12-month evaluation, but simply for the reasons of numbers and I guess getting the numbers in for AUA, they were presenting on the initial 88 patients with 3-month follow-up. And again, one-to-one randomization, the inclusion involved any prostate under 100 grams. So really wasn't much else in the determination other than not being in retention. They had to have an IPSS more than 13. And again, patients were either put toward Flomax or underwent a Urolift procedure. If you look at the characteristics of the data presented, the age was similar, 63 versus 61 years of age. The Qmax was similar between the groups, 15 and 15.2. PVR 98, 91, prostate volume about 40 grams. So that was what the included patients were. There was an opportunity to have a crossover. That wasn't presented, because that would have been done at 3 months. And what we did see at the 1 and 3 months in terms of the IPSS reductions, it was superior with the Urolift. So a drop down to about 11 and about 6, a drop to maybe 15 at 1 month for the two groups, and then a consistent drop to 10 versus 16 at the 3-month mark. Again, favoring Urolift as the primary endpoint. What was really unique also in their presentation, they also looked at BPH index, looking at the patient experience in terms of their psychosexual, other expectations of goals. So it's called a SAGA and a PPSM. These are unique, I guess, quality of life indexes, again, showing superiority of the Urolift to the outcome. So in summary, this is called the Impact trial. We should be seeing some of the 12-month data down the road, but at least the interim shows that this is the largest head-to-head open labeled RCT comparing efficacy, safety, and patient experience after a missed procedure. And again, comparing it to a medication, in this case, Flomax. And in this preliminary group of patients that were studied, the Urolift showed superiority to medication for better symptom relief with the IPSS, higher patient satisfaction scores from that SAGA and the PPSM, and more improvements in their daily activity. So again, longer term data is going to be forthcoming. But again, this is inaugural because it's the first time we've seen a missed randomized to a medication. So it was quite nice to see that. So one of the other studies that was highlighted, cracks into the growing space of missed procedures, specifically looking at stents. So there's certainly a stents 2.0 emerging with other studies enrolling patients or doing follow-up. There's a new stent that's also being evaluated. It's called the Flow stent by Rivermark. So this is abstract MP2704. It was delivered with Dr. Gilling and Dr. Elterman, looking at the initial acute outcomes within the first 2 weeks of the delivery of this unique stent made of nitinol that would, again, different than some of the other devices that are going to need a proprietary hand delivery system. This is a type of stent off the shelf that can be delivered through any cystoscope and as well easily be retrieved. So I guess this is what makes this unique. There were initial patients that were enrolled in different countries: Panama, Australia, New Zealand, Mexico. Mean prostate volume for these patients around 46 grams, ranging from 20 to 78. And the key thing was that the prostatic urethral length had to be between 2 and 5 centimeters. Anyone had to have an IPSS more than 13, the usual suspect parameters for inclusion. And all of the patients here had this delivered through either a Storz, an Ambu, or an Olympus flexible cystoscope, and then delivered. These were all successfully placed. And if any had to be repositioned using regular grasping forceps were all that was needed. So in short, there was a total of 27 delivered stents, and all patients voided spontaneously after delivery. There was no SAEs, severe adverse events reported. And again, the improvement in IPSS in 2 weeks, right off the bat, the patient walks out, no catheter. His IPSS dropped from 23.8 to 12.3 within 2 weeks. So again, something that's very unique. There's no damage to the urothelium. It can be delivered through any cystoscopes. You don't need to have a special set of equipment. In the wise words of Dean Elterman, he missed, a true missed, and off the shelf, no additional equipment or electrocautery or machinery is needed, and no catheter. So again, this is initial study looking at the Rivermark flow stent, a catheter-free BPH mist potential. And again, very early data. We'll see more forthcoming data down the road, but definitely a name to remember looking ahead toward the BPH stent progress. So, in keeping with some of the abstracts that were presented, there was one that highlighted the longest term follow up, real world data beyond the initial inaugural studies from aquablation. So, I think all urologists are very familiar or must have passed by the booth, one of the largest booths in the Cole Convention by Procept Biorobotics. And certainly they've come a long way in terms of publishing their notable amount of outcomes in the Water 1, Water 2, presently unrolling patients for the Water 3 trial. So next year's AUA, I'm excited to look at that. And that's going to randomize patients from aquablation to HOLEP out of Germany. So that's kind of a forecast of perhaps next year's AUA highlights. But at least this year, Dr. Kaplan and his team presented on MP2002, looking at their 4-year, the largest real-world single-center outcomes, looking at aquablation. So, all comers were studied. This was presented by Omodelli and Dr. Kaplan and his team. And what they showed was a prospective assessment of 265 men who underwent aquablation for their moderate to severe BPH, including some men in retention, middle lobes, the whole works. And this was all performed between 2019 to 2023. They capture that data. And in short, the average prostate size was 106 grams. This ranged from 38 as big as 293 grams. So certainly beyond, some of the Water 2 data. Some of these patients have also had PAE. Some patients had Urolift, underwent Resume. So a wide variety of men who were treated. And there was certainly a good number of those patients as well. About 41% of patients were in retention, were blocked coming in with catheter. And when you're looking at their 1-year outcomes, which is the bulk of their follow-up, they did have patients up to 4 years, but some of the numbers weren't as large as the initial study group. And certainly the volume dropped down to 41 grams, so about a 60% reduction in prostate volume. And with regards to the IPSS, that dropped from 24 down to 5.1. So, down to a single digit, very low. And like I tell patients, we never get you to zero. We're hoping to improve substantially your IPSS, and hopefully we'll get there before we have some bladder irritation or damage, dysfunctional detrusor. And again, I think the key elements is that, these patients also, well over 95% of men had preserved ejaculation. So I think that is an astute, detail of the team's proficiency, execution, understanding, the landmarks of the ejaculatory ducts and the hood. And I think as we're all listening to this, what we once thought in urology that it was all about the bladder neck in terms of antegrade ejaculation has been thrown out the window. And now we're realizing it's about preserving the verumontanum, the duct, and I like to call the magical tubes that go beyond the vero that we never think about or talk about. So there is some ductal system beneath that seems to be in the hoods and beneath. And if we can protect that for about a centimeter behind, better chance we preserve that. And at the same time, as this evidence comes out, what's really unique is we're seeing some of the other technologies. People are modifying their laser technologies to see if they can recreate that and deliver that same outcomes with those skill sets that they have for HOLEP and green light and what have you. So rather than trying to beat each other up and say, well, which one's better, I think we all have our own creative technology and techniques and those experiences. And if we can understand anatomy and follow those kind of principles, we learn the better. So again, this is a real world data evidence looking at 4-year outcomes, and those requiring surgical retreatments were 1.8. So some people are saying, what's the durability? Well, now we have real world, not cherry picked and a wide variety, some of these larger prostates, and the retreatment rate for this huge group of patients, some in retention, 1.8 at 5 years. So I think that's something to be said about this technology, which allows us to universally, democratically deliver the same surgery. So no matter what province, no matter what country or state you're in, if you had an aquablation, chances are you're going to get the same treatment, regardless of who your surgeon is or where it was delivered. That can't be said for a lot of other technologies or techniques where the surgeon experience comes in. So a democracy in BPH surgical outcomes seems to be very good outcomes. And with the future of having, a lot more men coming our way, passing that 60-year mark and men living longer, we're going to have to treat a lot of patients. And if we can do something that allows any surgeon of any age to do surgery in a much more comfortable, relaxed, less anxious environment with one piece of equipment in under an hour, not something to be said. This surgical time, under 1 hour, regardless of size, is something to be said for us as a surgical society where, burnout is still a big topic, anxiety, EMR overload, and, the other aspect. Do we have some technology with AI built in, kind of like we're seeing here, where that 1 hour of surgery, or less, there's half the time the robot's doing the work for us. So again, very nice presentation, and I foresee, further longer term data looking up to 10 years to answer the questions of durability. With regards to the evolution of some of the approved technologies, so one of them that we've seen, the most notable, Optilume BPH. I think most urologists are familiar with Optilume balloon for urethral strictures and its approval earlier on 2 years ago, and has really changed, outpatient stricture disease. Now that same company has moved on to develop a balloon that is inflated up to 90 French, up to 5 to 6 atmospheres for 10 minutes to dilate the prostate. They have 4 different sizes. It's called Optilume BPH, and it's coated. The second balloon is coated with paclitaxel, which once you get that distension of the bladder, of the balloon, sorry, into the prostate, you'll get this anterior commissurotomy. So we've all done our cystos. We have a compression of tissue, but if we can crack anteriorly, what we're doing is we're going to increase the height of that prostatic urethra. You're not going to necessarily change its shape or remove tissue, but you'll increase the height, making the urethral chamber that's slit higher. Same similar analogy to if we're getting something out of our suitcase, we want to get something at the bottom of our suitcase. You unzip the zipper another couple of inches, piece of cake, you get your hand in there. So the idea of resistance and radius and length, that's what we're doing with Optilume. And the paclitaxel helps prevent those two sides of tissue to aggregate and stick back together. Hence Optilume BPH. And so MP4603 studied in particular the sexual and semen parameters after treatment up to 12 months. So this feeds off of the initial Pinnacle and the Everest trial presentation by Copeland et al. From the group with Dr. Kaplan, Dr. McVary. And that was presented at the AUA. And what they studied was those, again, 2-to-1 fashion Optilume BPH versus sham. And at 12 months and between 3, 6, and 12 months, they studied the IPSS parameters. They looked at the ejaculatory semen parameters and the concentration of paclitaxel within those ejaculatory materials. And what was shown is there was a consistent improvement in IPSS. The Qmax, again, well over 20, one of the the most remarkable improvements in flow rates compared to any of the mist altogether. So that was again validated. And aside from the IPSS improvements, the key features here was that there were still a little traces of paclitaxel, not only at 30 days, but up to 3 months. And then beyond that, at 6 months, back to normal in terms of concentration. So I guess for fertility, for some young men, something to be thought of. And the other was the semen parameters were no changes. So for men looking to maintain not just their sexuality in terms of ejaculation, no retrograde ejaculation was noted. all the semen parameters, volume, and concentrations remain the same for this group. So again, optimal BPH not only has remarkable Qmax improvements, IPSS improvements, and some of the studies up to 5 years, but in this study, up to 12 months was validated. The unique features here, it did not impact the semen equality, ejaculatory numbers or volume. And just the only notable thing that the paclitaxel concentrations were still present at 30 days and traces up to 3 months and dissipation by 6 months. So with that, we'll can continue the ongoing implication of this technology in the BPH community. So following suit to the presentations on aquablation, there was another presented by myself, Dr. Zorn, presenting on the same-day aquablation, the first world global experience using aquablation in ambulatory care centers. So there certainly have been other centers, and us included for the water too, where we were able to have surgery and patients being discharged home the same day. But to have this done in an ambulatory care setting, so outside of the hospital milieu, has not been reported. So we presented on again, a minimally invasive, I guess, technology with robotics, as we all know, which combines and marries ultrasound for real-time imaging, personalized mapping, like 3D rendering of what we want, and then the delivery. Our printer is the aquablation, where we have 2 passes or more. And with it too, using selective cautery. So this is again a prospective study looking at men who were all delivered ASC between July and September 2023. We also had sort of a follow-up from our initial abstract submission to now 60 patients and a comprehensive assessment as the usual suspects of IPSS, quality of life, Qmax, PVR. And what was different in our series is that we actually used the loop to treat a lot more anterior tissue. So one of the limitations on aquablation, because the treating beam is treating below the actual metal sheath in the anterior space, there's some tissue in the anterior wedge that isn't as fully removed. So at the time of bipolar, we're using the Olympus bipolar, we resected a good amount of tissue anteriorly to get more comprehensive removal and get rid of the fluffy tissue down to capsule, more at the bladder neck and to mid-prostate. We left alone the apical tissues and the verumontanum, which is our preservation with aquablation. After which we delivered a Ruche 3-way 24 French catheter. 60 cc's were in the balloon, so making that bladder neck now circular, not just being sort of a wedge heart shape, but the circular nature allowed this Ruche oval balloon to wedge in, fit in, almost like a perfect fit. And that compression of the balloon could be delivered circumferentially as the shape of the bladder neck and the mid-prostate. But in some sense, that was delivered 60 cc's in the balloon. The cautery time was a bit longer in this series. But given this technique, with 60 patients, mean age of 68, prostate volume was about 115 grams. So from small as 41 cc's to 270 grams. Menin retention was around 48%. And in terms of the passes, 2.1 passes. There was very minimal hemoglobin change from 14.2 to 1.3. So very little changes there, no transfusions. And when we look at the post-operative irrigation time, about 4.8 hours of CBI transferred over to leg bag. All patients except for one, simply because we've come to realize that when we book these procedures, we start with the big ones early in the morning. We were probably doing about 4 to 5 in a day. So to do the smaller ones at the end of day. So that one patient that was kept overnight was 130 grams. We started him at 2 o'clock. By the time we finished at 4:30, that was an issue for keeping overnight. So that was the lesson learned. In looking at pain scales, very little that was dissipated by week 2. Complications, namely needing clot irrigation in the initial series where we did not use that Ruche catheter. And we've come to realize that's the importance of the hole with the end of the catheter. IPSS improvements, notably down to single digits like we saw for Dr. Kaplan, 6.6. and no surgical retreatment. So all minimal, mainly with bleeding, was the issues where the patients needed to do some manual irrigation. So the key messages for this abstract was a total of 60 patients, 98% were able to be discharged for these large size 115-gram prostates. There was no transfusions and there was no takebacks, nor was there any subsequent hospitalization. So it seems to be in well-selected patients and experienced teams' hands. Same-day aquablation is effective. It is capable to be being done at ASCs. And I know Dr. Mahamadi and a couple of others at other centers are now initiating, not just in the US, but globally, this technique in other ASCs. So again, what was once thought part of the water one, water two, this is a big bleeding risk and transfusions. We've come part one generation, the use of cautery. Two, I think we're able to do these now much more comfortably and in an ASC environment in well-selected patients. So more to be developed as we evolved, not only in the specialty of BPH and in the urology community, but also in our ability for techniques. And what will be in 5 years, we'll see. Certainly lots of evolution in this space. So I don't have a crystal ball in front of me, but certainly being at the meeting and seeing some of the stuff that's coming down the road, I think, if I was asked what is to come for AUA 2025 in Vegas, what do I see possibly being presented? Well, certainly I think we've covered the Water 3 trial that's underway and almost finishing recruitment. So that's comparing aquablation to HOLEP. So that'll sort of answer some of the questions. Is there superiority one to the other? Certainly, that'll be some initial 1 and 2 year data. We'll need longer term for durability. So I suspect that will be presented. We'll probably see some more of the stent data, possibly from ZenFlow, intraurethral nitinol stent. So I foresee that being the initial BREEZE trial coming to fruition. We talked about the impact that randomization of MIST, UroLift to FlowMax, getting that 12-month data. I foresee some of the presentations perhaps from Rivermark and a few other stent, Proverum being another. So they're moving along into their studies. So I suspect by next year, we're going to see almost the whole session really coming to points of data where we may be moving toward FDA approval. So I'm excited to see that. There's certainly other types of intraprostatic injections also being studied as well. So certainly there's a melting pot or a bubbling point. There's a lot of activity going on in the space of BPH. So certainly as we are as a community are going to be dealing with a lot more men, bigger prostates, living longer. We need to have office-based or MIST techniques that we can have off the shelf in the flow of things that don't take up our precious OR time. And those that do, perhaps technologies that are quick, fast, efficient, and other areas that I think we're going to be seeing some data on. And no one's ever talked about it during a timeout. We check with our, the patients. We have timeouts for our residents. Sorry, did you get your 40-hour weeks? But does anyone ever look at us as a surgical specialty? I know there's some studies now going on in terms of surgical stress levels. So what kind of metrics in terms of heart rate variability, serum cortisol, pupil eye dilation, measuring our stress levels. So during a BPH procedure, is there any input of, let's just say, for HOLEP or some other techniques where there's a lot of minute-to-minute micro details, management of bleeding that is compounded? And what does that look like in terms of the overall length of a life of a surgeon, male, female, in terms of our ability to perform? So I think that's something else that has to be looked at. And finally, if we take it back to a molecular study, when we look at BPH, we kind of measure, I consider it a bit of caveman technology. We measure X times Y times Z, and we multiply by pi over 6, and we get a volume of the whole gland. We don't take the time to measure what's the transition zone. So not every 80-gram prostate will have the same amount of transition zone tissue. And even deeper, not all 80-gram or whatever size prostate has the same components of BPH. Have we ever taken the time to think of stromal and glandular? So we're going to have some fluffy tissue that perhaps does very well with a MIST, and other dense tissue, we call that stromal tissue. And certainly people who do enucleation understand that when they're fighting these beach balls. And we don't really take time to know that until we're doing surgery. And we do these MIST procedures, and some patients do really well and some don't. That's, I think, the next level of order, be it with micro ultrasound or MRI or some other types of metrics, be it biologics. We compare it to prostate cancer. We have all these really cool biomarkers and imaging and PI-RAD scores. But for BPH, we got an ultrasound or maybe an MRI, X times Y times Z. We need to do better of understanding what kind of tissue we're dealing with and then prioritize the type of treatment based on that. Kind of like trying to paint on cement or wood or on some soft sponge tissue. Each one are going to take differently. That's probably why we're seeing those kind of results with MIST, at least. Surgery, well, you just blasting or lasering, it doesn't really make a difference. Maybe when you're morcellating. So, and the same question to be asked in medication care. So I think that's going to be our next order of tackling. And then ultimately, the question on my patients is, can we cure it? Can we stop this switch, this prostate puberty from starting? That'll be the holy grail. But until then, I think that's going to be our to-do list. And I think by next year's AUA, these are some of the stents and some of the longer term data we're going to see that will help guide us down the road.